So I think we are good to go, ladies and gentlemen. Thank you for joining us today for the third Malaria Week dialogue. And it's also the third online roundtable of the Malaria Game Changer series. And the title today is Harnessing Innovation to Accelerate Malaria Elimination and Strengthen Health Security. My name is Joost Wagner, and I'm going to be your moderator today. So today we are co-hosting this session with our partners at Medicines for Malaria Venture, PASS, and the RBM Partnership to End Malaria. So the Malaria Game Changer series gathers senior officials from Asia Pacific, but also malaria programs, national regulatory authorities, manufacturers, and global health partners. Through this series, we have been talking about existing and new tools and strategies to advance both health security and malaria elimination in the region. So in a second, you should see on your screen the list of roundtables that have already taken place and the ones that are planned for the rest of the year. As you can see, we are half time in our series, and there are two more to come, one in November and one in December. In this week, we also had discussions on the role of financing and surveillance in supporting strong health systems and supporting elimination efforts. So today we are focusing on the health commodities, including new diagnostic tests and treatments, and why is it important to ensure their timely access for all. So we will focus on a couple of topics today. So there is the discussion on the impact of COVID-19 on access to tests and drugs. We will talk about the rising burden of relapsing malaria PVIVAX as we approach elimination as a region. We are talking about solutions to address PVIVAX malaria from existing to new radical cure options, and finally, improving access pathways for all treatment options to tackle infectious diseases. Let me say something about the mechanics for today. So we would request all of you, and you probably have the three little dots on your video, to rename yourself to your actual name, and if you like, also your organization, if it still fits. So secondly, we recommend the people who are actually, we have two platforms, to use the speaker view of Zoom, to view the speakers on full screen. We highly encourage you to use the chat box, not only for questions, but also to share your views and comments. And also sometimes we might share some interesting links of documents that have been mentioned by some speakers. For the observer group, the audio and video capabilities are disabled, so you will not be able to unmute your mic by yourself. And please be aware that this roundtable will be recorded and shared on social media. This is, of course, especially relevant for our panelists today, so you have to look good at all times. So the discussion will take the form of a talk show. There will be no presentation today. And as I mentioned already, during the Q&A session, you can make use of the chat box to ask your question, and let's see how many we can actually address. If you have a question, please make clear to whom the question is addressed. So now I'm coming to the point where I can actually hand over to our co-chairs for today. So with us today is Dr. Le Vit Dung, Deputy Director General of the Drug Administration of Vietnam. And the second co-chair is Dr. Sandy Win. She's the founder and the managing director of the Myanmar Health and Development Consortium. So over to you, Dr. Le.
Good afternoon, everybody. I would like to thank the organizers for inviting me as a co-chair for this roundtable discussion on access to innovation for malaria, elimination, and for health security. It is my pleasure to welcome all esteemed panelists and the audience for today's Malaria Week dialogue. Our dialogue will focus on innovations and more specifically those that can help us address the rising burden of relapsing malaria, otherwise known as Plasmodium vivax malaria. To improve access to new medicines, the Drug Regulatory Authority has an important role to play. That is why we are pleased that the Drug Administration of Vietnam can participate in this session. And as was mentioned by my esteemed colleague, Professor Dương from NIMPE during the opening session of the Admin General Meeting on Monday, better access to radical cure options for relapsing malaria is critical if we want to get to elimination as a region. The APMA 5 years progress review for malaria elimination shows that VIVAC is one of the main remaining challenges to reach the finish line. So more than half of the global VIVAC burden is in the WHO Southeast Asia region. In fact, this burden is even higher in the Greater Mekong sub-region and Melanesia. While Vietnam has made great progress to elimination with a 90% decline in malaria cases since 2010, we understand the importance of accelerating access to radical cure for VIVAX, and 36% of our malaria cases are still VIVAX. So, our panelists, today we talk about what tools already exist to address VIVAX malaria, and how this can be used better, and how new tools might be able to help accelerate efforts. They will also talk about opportunity to improve access to these tools, and I look forward to hearing their views. So above all, I wish you all a fruitful and productive meeting, and I will pass on the mic to Dr. Sandy, our co-chair for this roundtable. So please, Dr. Sandy.
Thank you very much, Dr. Le Viet Tong, for your introduction, and a very well welcome to all the participants who are with us today. Let me share a few observations on the Malaria Game Changer series. Today's dialogue is part of a broader series on health innovation. Many of you joined the first two roundtables on the role of diagnostics and other health technologies. What is clear from the discussion so far is that health innovations are a key component of the fight against new infectious diseases such as COVID-19 and age-old ones such as malaria. Now, a few words on the technologies that we have against malaria and why we need to better harness innovation to get to elimination stage. I believe this region is fortunate to have access to a number of cutting-edge tests that can be used in the field to detect malaria cases quickly. We also have access to bed nets and insecticides to reduce transmission and artemisinin combination therapies that have been a key to getting us to this stage. But resistance to current treatment options is a problem. And we are constantly challenged by mosquitoes that are adapting faster than us, and as a result, it is becoming increasingly resistant to insecticides. And that's why we need tools, new tools, to keep one step ahead of the game to get us to elimination. So we need to continuously innovate and rapidly scale up proven new tools to stay ahead of the game. Today, our panelists will be asked how we can learn from our collective effort against COVID-19 in terms of pushing the research agenda and development timelines to resolve supply chain and access bottlenecks for malaria. So thank you all. I look forward to the discussions today, and let me turn it over to Jost for the moderation. Thank you again.
Thank you, Dr. Lee. Thank you, Dr. Sandy, for the welcoming remarks. And now that our session is officially open, I'm pleased to invite Dr. Kamala Trima, a senior researcher at the Menzies School of Health Research and the co-coordinator of the UPMEN VIVEX working group, to share some perspectives on VIVEX and some of the technical priorities as discussed during the recent online UPMEN Tech Talks you hopefully haven't missed. Dr. Kamala, over to you.
Thank you very much, Jost. And thanks for having me. Thanks for giving me the opportunity to provide a bit of an introduction into some of the challenges, but also opportunities in regards to VIVEX malaria that we'll be talking about today. So as Jost mentioned, I've been involved in the coordination of the VIVEX working group over the last 6 or 7 years, and I'm speaking on behalf of the working group and the co-chairs, Dr. Albi Bobogara and Professor Rick Price today. Over the last decade or two, we have seen great progress in terms of malaria control. In the last 20 years, 11 countries have been declared malaria-free, 2 of them in our region. But some of this progress has halted or even reversed, and the overall progress has been much more pronounced for falciparum malaria than for VIVEX malaria. Why is this the case? The main reason really lies in the difference between the parasites. VIVEX malaria has the ability to form those dormant liver stages that we call hypnocytes. And these forms of the parasite can stay in the liver for long periods of time after the initial infection without causing symptoms, and then cause relapse later on, so active disease again. In some areas, it is estimated that up to 80% of active episodes are caused by relapse. And this makes it really clear that strategies that work well for falciparum malaria only have very limited impact for VIVEX malaria. So treating both forms of the parasite, the blood forms that cause acute disease and then the liver forms, is usually referred to as radical cure. And so effective radical cure really is a key element for successful elimination of VIVEX malaria. So what are the challenges that we are currently facing with radical cure? The current recommended treatment is primaquine, which is a drug that has been on the market since more than 60 years. Almost all countries across our region use what we call a low-dose regimen, or at least recommended, over an extended period of 14 days. But there are massive challenges. We know that the 14-day course has relatively low effectiveness. A lot of patients just don't complete this 14 days. Particularly when the treatment is provided unsupervised. We also think that at least for some areas, the low dose might be not enough and a higher primaquine dose might be needed. We know that prescriptions of primaquine and radical cure is fairly low in a lot of areas, in a lot of regions. This is mainly due to concerns over the safety, particularly in patients who are G6PD deficient. And I'm sure we will hear much more about G6PD deficiency in this discussions today. And until very recently, we didn't have good point of care tests to identify those patients at risk. In this whole discussion, we tend to focus a lot on the risks of radical cure, but often forget to think about the benefits of radical cure. Just referring to some of our work in Papua, Indonesia, where we looked at more than 26,000 patients that were treated with radical cure in a routine setting, so outside of a nicely controlled clinical trial. Those patients who received primaquine had 20% lower risk of representation and 50% lower risk of hospitalization than those not treated with primaquine. Of course, those numbers are very specific to the context and the location. Again, the risk obviously depends a lot on the malaria endemicity and on the G6PD variance and prevalence. But it's really critical that we interpret those risks in the context of the benefits that radical cure can provide in terms of reducing the recurrent episodes of malaria and the associated morbidity and mortality with it. We know that in many cases, in many areas, we don't use the existing tools effectively. And we could make more effort, or we should probably make more effort to use those existing tools better. After all, as you know, Sri Lanka has successfully eliminated malaria without any of those new tools that we're going to talk about today. And Professor Kamini Mendis highlighted this really nicely in the last admin tech talk that Jost referred to, that the Vivex working group hosted. But of course, the good news is that there has been great progress over the last couple of years with new tools that are available now. And a lot of the conversation today will focus on how we can bring those new tools to those people who need them most. None of those new tools are quite the silver or golden bullet that we would like to have, but I have very little doubt that if we figure out how to make best use of them, this can have a significant impact on the malaria elimination agenda. So very briefly, what are those new tools? We have both treatments as well as diagnostic options. In terms of treatment, we have shorter primaquine courses, so using the same total dose of primaquine, but providing it over a shorter period of time, with the hope to increase adherence and therefore effectiveness. It's probably much easier to take 7 days treatment than 14 days, or ideally even shorter. And of course, we have tafenoquine now, which is a single dose and solves all these issues around adherence that I talked about, which obviously is fantastic, but increases the need for reliable G6PD testing at even higher enzyme activity thresholds than most likely needed for higher daily doses of primaquine. And that obviously reduces the population that could be treated with this new treatment. And finally, and I alluded to this earlier, we now have point of care tests for G6PD testing available that are really needed to ensure that those new treatments can be delivered safely. And this is particularly important for tafenoquine. Both quantitative and qualitative tests are now available, and I'm sure we will hear much more details in the discussion later on how they can be best used. There are obviously still some technical questions that remain to be answered, and a lot of people are working on those as we are speaking. But the overarching theme, and I guess the main challenge really is how can we ensure that access to those new tools for the populations that need the most. With malaria numbers going down, the cases are not in the big cities, are not in the well accessible areas, but are in remote areas that are hard to access. And we really have to think hard about how can we work together to create an environment that facilitates the introduction of those new tools into policy, but also more importantly into practice. So I'm looking forward to an interesting discussion today.
Thank you very much, Dr. Kamala Trima. And I think this sets wonderfully the scene. Let me say 2-3 sentences about the format today, or the flow. Today, the format is in the form of an online roundtable discussion. So the organizers have invited a number of experts, and I have the pleasure to ask them a few questions to hear their views on the role of innovations, particularly to deal with the Vivex malaria in the region. Afterwards, we will dedicate the remaining time for addressing questions from the audience, but we're also very interested in hearing thoughts and insights. So please make heavy use of the chat box and write your comments, questions, insights there. In a moment, I will introduce our guests for today, and I will do this in alphabetical order. But before we do that, we have prepared, as every day, a poll for our audience. So this simple poll will appear on your screen in a second. And the question we have for you is, in your opinion, what is the main bottleneck to introducing new health innovations in Asia and the Pacific? So choose one. I think you can only choose one. And this is for our participants here, all our government officials who are here with our speakers. Please look at your screen. You have 5 options: a complex fermented regulatory processes, lack of collaboration between regulators and disease programs for the review and prioritization of innovations, the price of new commodities, or financing or domestic budget procedure essential commodities, not to mention global policy recommendations. So what is the main bottleneck you see? Can you please choose in the next 20 seconds one of these, and then I will also display the results to all of you, I hope. So I give it another 20 seconds. So please look at the screen, select an answer. Okay, I think it's time to share the results. And I think that's very interesting. There is, on the one hand, especially the financing and domestic budget procure essential commodities, and then the lack of collaboration between regulators and disease programs. We are coming back to some of these points in our discussion. So thank you for participating. And now it's time for me to introduce you to our participants. Okay. So with us today, and I go, as I said, in alphabetical order, I have Dr. Avdesh Kumar. He's the Additional Director at the National Vector-Borne Diseases Control Program at the Ministry of Health and Family Welfare in New Delhi. More than 25 years of professional public health experience in program planning and management, and also strengthening M&E systems in the health sector, especially communicable diseases, including malaria and other vector-borne diseases. And he also led successful implementation of the global funds-supported intensified malaria control and elimination projects in northeastern India and other high endemic states of the country. Welcome. So second, we have Caroline, also known as Carrie Lynch. She is an epidemiologist and parasitologist working with Malaria for Medicines venture as a regional advisor for the Greater Mekong sub-region. Her current work involves working with national malaria programs and partners to strengthen P-Vivex case management, either by reinforcing current tools and also readying health systems for the introduction of new tools. And she worked before a lot in sub-Saharan Africa and the Asia and the Pacific. With us only by video today is Dr. Dareen Arichok-Chokchai, Deputy Director, Division of Vector-Borne Disease, Ministry of Public Health of Thailand. Dr. Dareen has 20 years of experience in the health sector, and she has been a medical epidemiologist at the Department of Disease Control under Ministry of Public Health Thailand for many years. She was appointed as a Deputy Director of Division of Vector-Borne Disease in 2019. So we have a short video with her key messages. Then with us today is Dr. Didik Budianto, the Director for the Directorate of Vector-Borne and Zoonotic Diseases Prevention and Control of the Government of Indonesia. And Dr. Didik was previously the head of Center of Data and Information at the Ministry of Health in Indonesia. And he has a master and a PhD in public health. And you might have seen him already on day one during the admin annual meeting. Then I go on to Dr. Gonzalo Domingo, who heads the malaria diagnostics portfolio and serves as a senior scientific director within the diagnostics global program at PATH. This portfolio seeks to improve access to quality rapid diagnostic tests for malaria case detection, as well as diagnostic tests for malaria case detection, rapid diagnostics for malaria case detection, as well as diagnostic tests that enable safe radical cure of Plasmodium vivax malaria, such as point-of-care tests for G6PD deficiency. So Dr. Domingo has driven this mission by fostering a portfolio of diagnostics technologies, and he works with public and private sector partners to advance these products from early research and development to in-country availability. Welcome, Dr. Gonzalo. Then with us is Dr. Jayita Chaudhary, the Program Director of India Health Fund, and which is seeded by Tata Trust in partnership with the Global Fund. At Tata Trust, Jayita is the lead for the strategic initiatives on health. And she also brings 2 decades of experience in the development and philanthropy, and she has worked extensively on reproductive and maternal health at South Asia level. Welcome, Dr. Jayita. Last but not least, we are joined by Robin Davis, the head of the Indo-Pacific Center for Health and Security at the Department of Foreign Affairs and Trade, also known as DFAT in Australia. So Robin was appointed as head of Australia's Indo-Pacific Center for Health Security based at the Department of Foreign Affairs and Trade in October 2017. He was previously the Associate Director at the Development Policy Center at the ANU, and before that worked at the former Australian Agency for International Development, AusAid. Welcome, everybody. So let's go right into it. But before we start, I wanted to give a quick recap of the key messages from the earlier roundtables on your screen. So there are three we wanted to share with you. So first, to get to elimination, in addition to existing tools, we need new technologies in diagnostics and vector control to prevent and test every case. Secondly, it is not just about R&D, but also about improving access and getting the tools to health workers and vulnerable populations at risk of malaria. And last but not least, decision makers, policymakers across ministries have a role to play in expediting the introduction of some of these new tools in countries. So I think we are good to go. And it is no secret that we are dealing with unprecedented times, and COVID-19 has shaken everything down to access to tests and drugs for other diseases. So let me turn first to Dr. Gonzalo with a very, very critical question. What is the impact of COVID-19 on access to commodities, including treatments for all types of malaria? Dr. Gonzalo.
Hi, yes. I think we don't know yet fully the impact of COVID-19 on access to malaria commodities such as diagnostics, which are the gateway to treatment. It's useful to break the question down to availability and access to these commodities. From an availability perspective, we do know a potential severe shortfall in supply has been averted thanks to the great and agile response coordinated by the WHO and global procurers through the Malaria RDT Procurers Task Force, and the resulting collaboration with manufacturers. Thinking about that case study, already before the COVID pandemic, we had a situation where the malaria quality RDT market was very consolidated, enabling low prices due to scales of economy, but also creating a vulnerable dependency on very few manufacturers. There was a very high risk that there was going to be a supply shortfall at the start of the pandemic for malaria RDTs in the short to mid-term, in part due to COVID, but also due to the systemic risks in the malaria RDT supply chain, and also the fact that many of the RDT manufacturers were responding to the COVID diagnostic needs. This is really where the WHO and RDT Procurer Task Force worked collaboratively with the manufacturers to address this risk and secure supply of RDTs in the short to mid-term. Actually, a potential long-term positive impact of COVID is diversification of the malaria RDT manufacturers, meeting the market needs as a consequence of this great collaborative effort. Flip side, we can anticipate a learning curve as these new suppliers scale up the malaria RDT manufacturing capacity, which may impact quality or supply timelines, which we can't anticipate until we start going through that. Another impact is less on the availability of RDTs, but on access. And this is something that unfortunately will vary from country to country, and the impact of COVID at a country level and the ability to get these tests to clinics and patients to the clinics. Here it's a combination of the impact of COVID on logistics and resources that may be diverted from malaria efforts, but also even healthcare provider and patient behavior changes that can restrict access to the tests and the treatment, even if they are available. I think it's extremely difficult to anticipate the implications of COVID on access at this stage, given our current uncertainties around COVID itself. But again, guidance from the WHO and other partners like RBM is important in kind of generating and supporting resilience to this uncertainty.
Thank you, Dr. Gonzalo. Anything you wanted to add?
No, that's
okay. Thank you, Dr. Gonzalo.
Yeah.
So maybe I move on to Jaita. I wanted to know from you, how can we leverage existing innovative technologies for TB and for malaria and adapt them for the use to test and treat COVID-19. Could you elaborate on that a little bit, Jaita?
Hi, are you able to see me?
Yes, we see you.
No, thank you for the question. Um, so I guess the reason you asked me about TB in this fora, which is focusing on VIVAX, is probably the background I come from. So I'm representing India Health Fund, as you said, and India Health Fund is actually an aggregator platform which was seeded by the Tata Trusts in partnership with the Global Fund. It was actually set up to support and accelerate development of innovations to address TB and malaria, and also ensure that these innovations are actually implemented across India. And of course, these can also be taken to other countries. So it's important to mention here that while we started working with TB and malaria, and this year, as we were faced with the whole pandemic crisis, it was very interesting that through the portfolio that India Health Fund has been supporting, on TB and malaria, we were able to, along with the scientists and innovators, we were able to repurpose some of the innovations from the portfolio to address COVID actually. So essentially what happened is that the kitty that we had in terms of the innovations, most of these were in the space of either screening and diagnosis or surveillance, or and these were able, all these innovators were able to step up, and actually they have been working on platform based solutions, and that is what made the difference, that they were able to address the whole COVID screening and testing in India through the platform-based, because these solutions were all multi-device platform-based solutions. While they were initially working only on TB, only on malaria, but they were able to adapt very fast to the growing crisis, and were able, and we're happy to share with you that out of our overall 8 innovations that we have been supporting, 2 have been able. One is a platform called TrueNat, developed by Mall Biodiagnostics. It's an Indian company here, and they were able to change accordingly. And recently, they also 2 months back, Mall Biodiagnostics was able to receive approval from the Indian Council of Medical Research. Not only earlier they had received approval for TB, but recently they received approval for COVID screening, and this is currently being used in various parts in the country right now. So that's one. The second that we have seen is in terms of AI-based solution, which we were actually supporting for TB screening. So it's a imaging technology, supported by artificial intelligence, which was earlier helping TB, screening. Again, they were able to step up in the last few months, and that AI-based mobile app started getting used for COVID. So basically what it does is looks at, or the lung damage, so instead of screening, this particular same solution is looking at progression monitoring, once a person has been confirmed with COVID. So there are these examples, and then there are other examples also, in our kitty. So essentially what we feel is that all these will definitely need an emphasis on fast tracking approval, the regulatory approvals as well. That is very critical. And I think I just want to flag one issue that, while we talk about diagnostics and treatment pathways and approvals on that, one issue that at least we have been, we have learned about it recently is in all these AI-based solutions, what is the regulatory approval? Does different countries have a separate regulatory mechanism for those? Because a particular solution may be CE certified or be certified in another country, but is it applicable to individual countries? So for example, I was talking about this particular AI-based mobile app for screening and progression monitoring. It has CE certification, but can it be scaled up widely? And what are the regulatory frameworks? So I think the way innovations are being promoted and supported, we need to see, we also need to probably expand and increase the dialogue and expand the scope of regulatory approvals, even when it comes to looking at AI-based solutions. But otherwise also, I think it's very, very important to see, given it's not just the pandemic, but even in the context of the national goals of malaria elimination, we'll have to see how we can work very closely with the government, with the scientists, with entrepreneurs, private sector and funders to ensure that whatever solutions are there are stepped up, are getting the adequate support from building a conducive environment.
Thank you, Jaita, and thanks for raising the point of how important collaboration between all the stakeholders is, and also sharing about the work you're doing at the India Health Fund, supported by the Tata Trusts. Let me talk to our colleagues from Indonesia and India next. I would like to understand a little bit more what we are dealing with here, the burden of Vivax and relapsing malaria in the region. Maybe I start with Dr. Didik from Indonesia. So how varied is the prevalence of P. Vivax in Indonesia?
Okay, thank you. Yes, according to this question that we have, about 250,000 malaria cases last year. And about from this, 90% of it reported by the eastern part of the country. Among the total cases, 25% are Plasmodium vivax. Yeah. The rest are almost all Plasmodium falciparum. We have few cases about Plasmodium malariae, Plasmodium ovale, or knowledge. So all provinces reported Plasmodium vivax with a prevalence varies from 33% to 61%. In low endemic area, vivax malaria cases is relative dominant. I think that is my experience. Thank you.
Thank you, Dr. Didik. And maybe let's go to India. Dr. Advesh, India has a high burden of Vivax cases. So could this have an impact, in your opinion, on the 2030 elimination targets?
Thank you, Jost. After launching the National Framework for Malaria Elimination in India, that was in February 2016, we have achieved remarkably significant success in declining the malaria. Morbidity has declined by 71%. The mortality has declined by roughly 80%. If we look at long-term decline of malaria in last maybe 19 years, compared to 2001, the falciparum has declined by 84% in the country. Similarly, the Vivax has also declined by 83% in the country. So that way, the decline rate is similar in both the cases. But of late, in last 4 to 5 years, if we look at this data, the falciparum has declined much more compared to the Vivax. Say, for example, in 2019, the Vivax is around 54%, and the falciparum is around 46%. And we also know that as we move nearer to malaria elimination target, the falciparum goes faster, the Vivax goes later. Considering that this may have an impact on malaria elimination target of 2030 for the country and the globe also, we are considering all options which are available to us. We have a shorter regime of actually primacoin of 7 days. We have a single dose actually tefenocoin. So we are considering, we are assessing all the aspects of this, so that we do not let the Vivax impact the malaria elimination in the country. Thank you.
Thank you, Dr. Didik. Thank you, Dr. Abdesh, for the overview of what's happening in Indonesia and in India. I wanted to go back to Jaita Chaudhry, and I wanted to continue a little bit on this line. And my next question was about what can be done to accelerate access to innovations in India, but also other geographies. You already mentioned the importance of collaboration. Could you elaborate a little bit more on how we can accelerate access to innovations?
Yeah, no, that's a very valid point and valid question actually. So I have about a bunch of 5 or 6 points which I want to make here. So number one is that I think while there has been focus on various aspects of malaria elimination, what has actually not picked up at that much is in terms of developing innovations, and I'm referring to both product innovations and process innovations. So while we always look at gap filling, somewhere product and process innovation do get less attention or less resources as well. So it's extremely critical, for the community I was mentioning earlier, whether it's the scientists, entrepreneurs, private sectors, and funder, we need to come together and work very closely with the government. Number one, on identifying the right problems. Because if we may, develop a pipeline of innovations which may not be required for this moment, probably in the drive for malaria elimination. So hence, my first point is identifying the right problems and gaps which can be solved by product and process innovations, number one. Number two is that, whatever innovations that are already there, but not yet received approval, regulatory approval, we need to work very closely with the government to see how those can receive timely approvals, after the validation process. And next is, once it has been approved, let's say in India, how can we take these, or in another country, how can we take it to the other countries? What would apply? What would it take, for example, for the WHO pre-qualification? So how that, and therefore the cross-border collaboration will become very critical in terms of what you're asking. And I think I want to share one example from the kitty that India Health Fund is supporting. We have something called HEMEX, we have something called EcoBiotraps and Track It Now. And each of these, we are talking to various players a lot with the national program, AppleMa and many others, to see while these are being developed and supported in India, how can it be scaled up in other geography as for the need? A third point is that, it is not just adequate to, support the development, but also have the implementation plan, and with a focus on the key population. That is very, very critical. How will these be scaled up? How will these be accepted by the communities? What training and capabilities will be required by the health workforce to adopt these? So that entire implementation plan will become very, very critical. But I think it would be absolutely incomplete if I do not emphasize adequately on partnerships for funding. There is very, very limited resources available actually for innovation development and innovation implementation. That is very critical. And I think we have to be very careful about not supporting suboptimal, solutions, but so coming together to support the right solution, raise and aggregate resources for the lasting impact, have definitely come up with a scale-up plan for individual countries and a group of countries. And most importantly, we cannot go anywhere without working with the government. Just want to end by saying that on this chat box, I'm going to share a note of the innovations that we are supporting. And if anybody is interested, we can always carry discussions beyond this meeting. Thank you, sir.
Thank you, Jayita. And actually, this brings me to the current solutions and tools that we have to test and to treat Vivax. So maybe Dr. Didik, what are the different strategies you are using in areas with high risk of relapse, such as Eastern Indonesia and Papaya? You mentioned 90% of malaria cases are in the east of the country, 25% are probably Vivax. So what are the strategies you are using in these areas?
Okay, thank you, Josh. Yes, in the whole country, the protocol to diagnosis malaria is using microscope in the health facility and RGT in auxiliary facilities such as village health posts and during active case detection by community health worker. Protocol to pivot malaria treatment is also similar for the whole country. Something like ACT, DHP, plus 14 days low dose primaquine, 25 milligram per kilogram body weight without G6 PD testing with monitoring of hemolysis sign and symptom. The second, if the patient has repeated visit and suspect to have PV relapse, the dose, primaquine dose could be increased to 50 milligram per kilogram body weight with close monitoring of hemolysis and hemolysis sign, and symptom. And the third, in any case, if a patient has hemolysis sign and symptoms, the primaquine dose shall be modified to once per week for 8 weeks. In practice, however, most of clinical only using the 14 days low dose primaquine. Our experience in eliminating malaria district by district show that if cases become fewer due to success of malaria reduction, we move to observe or closely monitor malaria treatment by community health workers to ensure compliance. This way, we could eliminate malaria. However, our malaria researchers in Papua have documented high PV relapse with current protocol due to poor compliance to the 14 days low dose regimen. We have just finished our annual malaria research in Indonesia meeting 2 weeks ago, and with the new developments was presented, including 7 days high dose primaquine regimen and the last research on G6 PD point of care testing. Our treatment protocol. Our treatment protocol for malaria is formulated based on the recommendation from our expert community in malaria diagnosis and treatment. We will convince the expert meeting to discuss this finding, and if new recommendation will be made by expert committee to us in the MOH, Ministry of Health. Our control strategy is Eastern Indonesia, including Papua, remain. The first, reduction malaria transmission by conducting mass distribution of long-lasting insecticidal nets, LLIN. And the second, achieving universal access to malaria treatment by involving public and private health providers, as well as through active case finding by our community health workers, who conduct regular home visit to look for malaria cases and to monitor compliance to treatment and prevention. So we will continue elaborating the feasibility of implementing high-dose primaquine with our expert committee in the context of G6 PD, efficiency distribution, and the country. I think that's all is my explanation. Thank you.
Thank you, Dr. Didik, for this detailed answer. And let's turn to India, actually. As far as I remember, current policy in India requires a 14-day treatment with primaquine in case of Vivax malaria, Dr. Avdesh. So I think that's correct, right? So what are some of the challenges with this treatment regime? You have to unmute your mic, Dr. Avdesh. Yes, thank you.
Thank you, Jost. As you have said, that the policy as of now for the Vivax malaria treatment in India is 14 days of actually primaquine. But the question is that as the fever and other associated symptoms, they go much shorter. So there is an issue of compliance of completing 14 days of treatment for the patient. So that's one actually challenge. Though now we are advising supervised treatment by the health worker, but 14 days compared to the falciparum treatment of 3 days. So that compliance on the part of health worker is also there. So few of the patients may not be able to complete 14 days of treatment. Now, how do we take care of these issues so as to achieve the malaria elimination target by the 2030? What we have done is we have made available now diagnostic as well as the treatment services available at the village level through the health of a worker, which is known as ASHA, accredited social health activist. This is a voluntary worker who works on the basis of incentive for the work done. So we have revised the incentive for ensuring complete treatment of a single case. It was 75 rupees till now. We are revising it to rupees 200 per case now. So that would be an added incentive for this worker so as to ensure complete treatment. We are also looking at other challenges, as I said earlier. The shorter course regime of 7 days and the single dose of the tefenoquine. But the challenges with these are, the number one is that we do not have the facilities of diagnosing the G6PD deficiency at village level as of now. So that's a challenge for us. So we need a actually point of care diagnosis test. If we go for tefenoquine. The reason being because the tefenoquine dose would be given as a single bolus to the patient. So whatever side effects are there, they would happen much faster.
Thank you, Dr. Avdesh.
There was a study that the tefenoquine side effects are a little bit higher compared to now actually the primaquine dose. So all those issues we have, and we are considering them according to the policy as well as these operational issues so as to take care of these challenges. Thank you very much.
Thank you, Dr. Avdesh, for highlighting some of these challenges. And I would like to go over to Robin Davis, the head of the Indo-Pacific Center for Health Security. And the Australian government supports a lot of initiatives for malaria elimination in the region. And we are honored to have you here, Robin. How is the center supporting the scale up of existing Vivax intervention? Can you elaborate a little bit on this, Robin?
Yeah, thanks, Jost. So you referred to the centre, which is the Centre for Health Security within the Department of Foreign Affairs and Trade, which I head. The centre was established in late 2017 to really intensify the Australian government's work on infectious disease prevention and control across the region. It's not disease specific, but it is supporting a range of activities that do target malaria, HIV, TB, and a range of other infectious disease threats facing the region. I think the principal change in the way we have supported malaria control and elimination, including Vivax malaria control since that time, is to take a more end-to-end approach. If you look back 3 or 4 years, at that time Australia was supporting a number of product development partnerships, including, excuse me, my light has just turned itself off, including the Medicines for Malaria venture, the Foundation for Innovative New Diagnostics, which are particularly relevant in the malaria space. And we were a consistent supporter of the Global Fund in terms of rolling out bed nets, treatments, and so forth. But with the advent of the Health Security Initiative, we've done a couple of additional things. We continue to be a strong supporter of the Global Fund and in fact increased our contribution substantially at the last replenishment. But focusing on malaria specifically, there are really 3 things I would highlight. First, we extended and expanded our support for the relevant product development partnerships quite significantly. For the first time, we entered into 5-year agreements with both MMV and FIND. And to that, we added a 5-year agreement with the Innovative Vector Control Consortium. There are a couple of other PDPs that I'm not including Higgs, they're not relevant. But that sort of long-term commitment is something that the PDPs really crave, really need, combined with flexibility of funding, which we have also given them. We have not sought to tie our funding to specific purposes. We are supporting the full range of their work. Secondly, we have put in place the Regional Regulatory Strengthening Program, which brings to bear the resources and the skills of Australia's Therapeutic Goods Administration for the benefit of 6 countries in the region, 5 in Southeast Asia plus Papua New Guinea. And that program it's still relatively new, but I think it's beginning to play a significant role in fostering the exchange of information between national medicines regulatory authorities in the region, transferring technical capacity from Australia's stringent regulatory authority to those in the region, and also supporting the registration of specific products. And I'll come back to that in a second. And then the third thing we have sought to do, I mean, we are here at a forum being sponsored by APLMA and APMEN. Australia, together with the Gates Foundation, are the 2 key donors to APLMA and APMEN. We have jointly negotiated a new funding agreement, jointly between Gates and DFAT, a new funding agreement for the several years ahead with APLMA and APMEN. And a prominent sort of part of our discussions, our negotiations with APLMA and APMEN in agreeing funding for this new period was a stronger role, a stronger profile for APMEN, including, of course, its VIVAX working group, which has always, I should say, had quite strong input from Australia, and in particular the Menzies School of Health Research. So broadly, that's how things have changed since the Centre for Health Security came along. Specifically, of course, you're all aware of the role that MMB, together with GSK, has played in the development and registration of tafenoquine. I confess we do not currently fund PATH, sorry, Gonzalo, but our support for MMV is, of course, indirectly supporting work on diagnostics for G6PD deficiency as well. Our support for FIND is helping them to develop diagnostic tools for VIVAX malaria, and our work for our support for the Innovative Vector Control Consortium is really across everything they do, supporting VIVAX malaria control simply by virtue of the fact that more than 70 species of mosquito do carry that that particular parasite. So I think that's it in a nutshell. And so we've really tried to work across innovation, regulation, and access through our support for PDPs, the role of the Therapeutic Goods Administration in the region, and a stronger role for APMEN. I'll stop there.
Thanks, Robin. Actually, I had a question prepared, wanted to ask a little bit about new approaches that are available to accelerate control of or against VIVAX malaria in countries nearing elimination. Could you elaborate on that for maybe 1 or 2 minutes? Are there new approaches available?
Yeah, well, I think that's particularly where the vector control technologies are particularly important, as well as the introduction of the radical cure that is tafenoquine. TGA, the Therapeutic Goods Administration in Australia, has worked particularly closely with the government of Thailand to register tafenoquine for Thailand, and we hope that will then facilitate the rapid registration of tafenoquine for use in other countries in the region. So I think it's that particular innovation plus the tools that are being developed by IVCC that could play a particularly strong role in helping those countries that are close to elimination to get across the line and then stay there, because maintaining elimination is itself a significant challenge.
Thank you very much, Robin, and thanks for the support of the Australian government to end malaria. Let me go to Kerry from MMV. She's a key member of the With Access project, with whom Appelma is also closely working. Kerry, you have been engaged in the implementation of different radical cure options, including new tests and treatments. So where and how are these new tools being used currently? And what can we learn from the experience or experiences of these countries? Kerry, can you?
Hi, hello to everyone, and thank you so much for the invite to be here. So I think it's important to say from the get-go that not many of the new tools that are becoming available are being implemented in routine practice as yet. And the reason for that is because, you know, we're at this exciting stage where we've got these products coming down the development pipeline, or where evidence has been generated, for example, on PQ7 efficacy. But we do need to answer a whole host of questions about the operationalization of those new tools, and to speak to some of the points that our colleagues have already made. So we need to figure out, you know, with national malaria control programs and ministries of health, whether they want to deploy these new tools, but importantly, where they want to deploy them, given the variability in virus transmission, and also how they can deploy them safely, and how they can deploy them so that we have access given to where the Vivax caseload is highest. So just to answer then in two parts, what kind of operational research is ongoing at the moment to facilitate that kind of evidence-informed decision-making in the future. Firstly, there are a number of partners who've been working on operational research on the G6PD test and the point of care diagnostic G6PD test. So for example, we've got Dr. Siv and Dr. Sole as part of the CNM program in Cambodia have piloted the qualitative G6PD rapid diagnostic test. AFRIMS have done some great work on the usability of different point of care quantitative G6PD tests. Our colleagues in PATH have been working with both SIMPE in Laos and NIMPE, they're preparing a study in Vietnam, on the usability of the quantitative G6PD test as well. And then on the treatment side, Dr. Kamala of Menzies is working on looking at the effectiveness, so not the efficacy, but the effectiveness of these different treatment regimes. So PQ 7-day versus Primaquine 14-day versus Tafenoquine single dose. So that's what a whole host of other partners are doing. For the Vive Access initiative, so this is an initiative between MMV and PATH. And what we're working on at the moment are preparing studies in Brazil and here in Thailand to look at the quantitative G6PD usability, but adding in Tafenoquine. So how can health service providers use a treatment algorithm with those two new tools now in this new treatment algorithm? And how does that change, or does it change as you go down the health system levels? So does it change in hospitals versus more peripheral levels? In Brazil, we're also looking at acceptability of the new tools by both the providers and the patients. And they're also going to be estimating cost effectiveness as well of the new tools. We're hoping to do a similar study in Myanmar, pending some funding, also on Tafenoquine and the Quanti G6PD. And then we're working onto that same stream of funding with our colleagues in Menzies and Burnett, who will be hopefully doing large-scale studies on PQ7 effectiveness with G6PD testing as well in those countries. So just to summarize, I mean, at this stage it's exciting, but there's still some more steps to go so that we can try and inform that decision-making that will happen in 2, 3, 4 years' time to integrate the new tools into policy.
Thanks, Kerry, in highlighting the feasibility studies. That brings us to a critical issue that needs to be considered. Radical cure needs to be introduced safely with associated tests to test for G6PD deficiency. So which tests are available or will soon be available, and what should we be aware of?
So I think that's to me. I think it's first important to recognize that after years of no innovation in diagnostic tests for G6PD deficiency, over the last decade, we are seeing finally the emergence of several point-of-care G6PD tests. Interestingly, this is an example of actually a neglected disease, P-Vivax for malaria, driving innovation in the field, G6PD deficiency, that has clinical benefits beyond just malaria. It's also an example of a combination of both manufacturers committing to meet this need and the effectiveness of the PDP model, resulting in commercially available products that can bring equitable access to radical cure in remote populations and where there is a high G6PD deficiency prevalence. So what does the pipeline of G6PD tests look like? On the qualitative G6PD test, we already have one qualitative test in the market manufactured by Access Bio. And it's worth recognizing that Access Bio was the first manufacturer that on its own initiative sought to address this need. The test is currently not available, unfortunately, but we hope that this will be resolved shortly. And we know many partners are working with Access Bio to address this, with what's holding its availability up. There are at least another 2 qualitative G6PD products that are progressing towards commercialization. These tests, including a new generation of the Access Bio CareStart test, include control lines which will significantly improve the confidence and the performance of these tests. And we hope to see these entering clinical studies shortly. These qualitative tests can provide access to current primacrine regimens to a vast majority of people. It's worth mentioning, though, that it is hard to make these tests such that they perform robustly over wide operating conditions that represent malaria case management in the countries where Vivax is endemic. However, the new and game-changing regimens that are arising, such as the single-dose regimen developed by GSK and MMV, tafenoquine or Cosentyx, will require a quantitative or semi-quantitative test that can also identify females with intermediate G6PD activity that, according to the label, should not receive the drug. Again, here, there is already one product that may address this need, the standard G6PD test by SD Biosensor, and that has already received the RPD approval by the Global Fund for Procurement and is registered in many malaria endemic countries. This product is currently undergoing stringent regulatory review with both the US FDA and the Australian TGA. This test does provide an opportunity to provide equal access to the same standard of care to both males and females. There are also at least 3 other quantitative G6PD products currently under development targeting the P-Vivax case management, including one from Access Bio and another one from a company in the US called IVDS. To reiterate Kerry's points, a critical piece will be to understand how to introduce these tests into malaria treatment algorithms and practices. Again, here, there is already a lot of work progressing in the form of operations research led by MCPs, as well as organizations such as Menzies Find, MMB, PATH, and others. The Atman Vivax working group has really been critical platform in creating the awareness and sharing knowledge amongst the partners. And it's worth mentioning that many of these efforts have been, of course, funded by TFAT and DFID, now FCDO. In brief, I think we finally have tools to roll out radical cure to those who need it most and avert unnecessary illness, and we are really moving forward positively in a way of learning how to use those. And stop there.
Thank you, Dr. Gonzalo. Kerry, in your opinion, what can countries do to accelerate policy change towards a safer radical cure?
Yeah, so I think, well, from the Vivax side of the point of view, what we're trying to do is work with national programs and country coordinators that we work with in the Greater Mekong sub-region, and to take a really proactive approach, proactive view of looking, say, 2, 3, 4 years down the line when a policy change might happen, and then figure out, okay, what needs to be in place to, first of all, facilitate an evidence-informed policy change that is rigorous, but that's quick. And also then what needs to be in place to ensure a smooth and a safe and effective rollout of the new tools in whichever combination that ministries of health and national programs choose to deploy them. So if you think of that in 3 kind of stages, I mentioned the operational research. that's going on, you know, both by Vive Access and amongst many partners. And Gonzalo mentioned the ATMEN Vive Working Group. They have generated a huge amount of evidence around this area. And what we're trying to do at the moment is collate all of that operational research into a database. And then we'll be housing that on the vivaxmalaria.org website in a few weeks. But the aim of that is so that we can have a look and see what research is going on and where there might be gaps in terms of questions that programs still have when it comes to policy change. So that's the first thing. And the second thing we're doing is we're looking at the policy change process, the procurement processes. So just to Jaita's point about process innovation and how perhaps less sexy that is, but how important it is and crucial it is, what we're trying to do is map out the policy change processes and figure out, okay, if in the last time you changed a first-line treatment for malaria, it took 2 years, why did it take 2 years? What were the delays? What were the bottlenecks that caused that to be such a long timeline? And are there things that we can do now to mitigate the risk of delays in the future to ensure a rigorous but a quick policy change process? Same thing for procurement, and we're mapping out the procurement processes. If it takes 1.5 years to get a product in country right now, what is it that causes that delay? You know, who are the ministries that we need to talk to try and shorten that timeline? And I think this is where it's quite important for national programs, once they've identified those bottlenecks, to have support from more senior levels of the Ministry of Health to facilitate the actions and the activities they need to do to shorten those timelines and to ensure a smooth kind of quick processes as the new tools come on stream. And then the last phase that we're looking at is the policy implementation side of things. So we're trying to think with our National Malaria Control Programme colleagues, what do we have to have in place in the health system now to ensure a safe and effective rollout of those new tools once the policy is changed? So that we're smoothing, the road, we're creating a nice smooth pathway for them to be implemented quickly. And one good example of this is actually speaking to one of Robin's point on the RSP, the Regional Regulatory Strengthening Partnership, is we've identified in a few countries the need to strengthen the pharmacovigilance systems. So we're trying to work with national programs to figure out, well, how can they coordinate better with the pharmacovigilance units in countries? How can we integrate adverse event reporting into the system, to acknowledging that aminquinolines, whether it's primaquine or tafenoquine, all need to, there is a risk associated because of G6PD deficiency, and we need to be able to identify, respond to, and report any adverse events that come up. So again, that's just an example of what we're trying to do to strengthen the health system. So we're not scrambling once a policy change is made to do something that takes 2 to 3 years. We're paving the road ahead of time, and hopefully all of that will contribute to a quick policy change process and a smooth and safe implementation of new tools to allow countries to get to their elimination targets.
Thank you, Caroline. And I have 3 questions left. So before I ask them, make use of the chat box. If you have questions, you can write them there and you can mention who you want to address. And then I'm gonna go now to our colleague who couldn't join us live today, and we talked with her about introducing new tools in the regulatory process. So Thailand adopted a reliance model for registration of the new drug tafenoquine as radical cure for Vivex malaria. So Dr. Darin was so kind to talk to my colleague Ritika. So let us hear what Dr. Darin has to say about this.
I have to explain that routinely the Thai FDA has 3 mechanisms for the drug registration. The first mechanism or first channel is that review, which most of the drugs go to this channel. The second channel is priority review. The drug that have urgent need for the public health will go to this channel. And the last channel is, they call it a bridge review for the drug that already approved by the strong regulatory authority, like already approved by WHO, by US FDA, or the Australian TGA. So at the beginning, when we informed the Thai FDA that we would like to conduct a research of the tafenoquine for the radical heal. The Thai FDA have consulted with the Australian TGA because at that time the drug, the tafenoquine, already approved by the Australian TGA. So the Thai FDA consult the Australian TGA about this drug and the process to be registered. They send few staff, 2 or 3 staff, I'm not sure, to the Australian TGA and learn with them about the risk management plan. And when they return to Thailand, they talk back to the Department of Disease Control on that for the mechanism to register the tafenoquine in Thailand, they would like to put it into the priority review. That means only they will accelerate the process of registration. I mean, usually they may take like almost 1 year, but the process will be shortened to only 3 or 4 months. But not only the document review, but we also have to develop the risk management plan to minimize the risk of unexpected events that may occur. So after that, the Thai FDA conduct 3 workshops supported by the WHO and Australian TGA about the risk management plan, how to develop risk management plan, how to develop risk minimization tools, what is the pharmacovigilance, and also the causality assessment. So all of the workshop use tafenoquine as a model for discussion, and that is the learning process for us, for Thai FDA and also the Department of Disease Control in Thailand. So after that, we collaborate with Thai FDA and also the drug manufacturer. We developed the risk management plan and risk minimization tools, for example, G6PD patient card. We also developed the guideline for refer the patient of acute hemolytic anemia if occur from the local hospital or community hospital to the tertiary care center. We developed the checklist for signs and symptoms of side effects, for serious side effects such as hemolytic anemia. All these two already included in the proposal and the protocol that we are going to implement in the study site. So after they review, the Thai FDA review all the documents and work with us for the risk management plan, then it takes about 4 or 5 months to register the tafenoquine in Thailand. So we got the registration already in December last year.
And thank you very much for showing that video. And actually, we asked a second question. We asked Dr. Darin on how the Thailand Division of Vector-Borne Diseases collaborate with the Thai FDA to introduce new drugs and diagnostics. So here's her short answer.
I would like to explain to you how we work with the Thai FDA for the, any new drugs or tools that we are going to use in Thailand. Under the National Malaria Elimination Strategy, we have a committee that we call National Anti-Malaria Drug Committee. They are the technical advisory group that provide guidance for the anti-malaria drugs that should be used in Thailand. This committee has experts not only from the Department of Disease Control, but we also recruit experts from the Thai FDA into the community. We also recruit the experts from university, from research institutes, and the meeting will be conducted every 6 months, approximately. So every 6 months, this committee will review the anti-malaria drug regimens that we use in Thailand, and provide information about the new drugs that used in other countries. So if we would like to innovate something, for example, we would like to conduct a research for new drugs or any new tools, we will inform the Thai FDA through this committee. So they already there sit in the committee, so they know what happened. They can hear from other experts from the research institute or university, and then the Thai FDA will understand the reason why we have to implement some innovations. So for example, tafenoquine, when they know the reason or the rationale why we have to use tafenoquine in Thailand, then they will proceed they will support us in terms of the registration. It's our routine system that we have the National Malaria Drug Committee that we already involved Thai FDA, and we work together routinely, at least every 6 months, that we have to sit and talk and inform each other what needs to be done to support the malaria elimination.
So this was Dr. Darin, and I think this was some interesting learning from Thailand. So my very last question before we go over to Q&A, I wanted to go back to Robin Davis. So what are some of the lessons learned around stronger regulatory systems that are relevant for countries to support their response to COVID-19? Last question.
Yeah, I mean, I think Dr. Darin has sort of described the case study of the relationship between the Therapeutic Goods Administration and its Thai counterpart, which I think has been very successful, and I have to say not really foreseen in the design of the regional program, which was focused on 6 other countries. There was an expectation that Thailand would be playing a partnership role with the TGA in some of those other countries, but the experience of the registration of tafenoquine in Thailand is something that wasn't particularly foreseen and was a very successful process, and we hope that that will be repeated for other treatments and potentially vaccines in the future. I think the principal lesson, if the focus is on lessons learned to date from this process, I think the principal lesson has been about the value of really establishing country-specific relationships between our regulator and those in the region. I think when the regulatory strengthening program was designed, there was a strong emphasis on regional harmonization, an ambition to achieve reliance and recognition between regulators within the region and between countries in the region and Australia or other stringent authorities. But I think it's become apparent that that is quite a long-term ambition. It's a very complex process to achieve that kind of harmonization, as we've seen in the ASEAN context. But what has worked particularly well is the formation of really strong, tailored personal relationships between Australia's regulators and those in the 6 countries that are participating in the program, plus Thailand, which is less a beneficiary and more a partner. And then particularly exploiting some of those strong bilateral relationships to then provide benefits to third countries, which I think is what we're going to see as a valuable spin-off of that support that has been given to Thailand in relation to tafenoquine. Now, obviously, we hope the work that has been done to date will stand all countries in good stead in relation to COVID-19 vaccines and treatments. For example, on the treatment side, Australia is one of a fairly small number of countries that has provided market authorization, emergency use authorization for remdesivir, and therefore is well positioned to work with countries in our region to provide similar authorization. And the same may be true within the next, let's say, 12 to 18 months in relation to some early generation vaccines. So that's what I would focus on particularly. I think harmonization is a medium to long-term aim, but just really investing a lot in the development of direct relationships between regulators in all directions is really likely to provide the biggest payoff in the short term. Over.
Thank you, Robin Davies. Actually, thanks to all panelists for answering all my questions. I think we have learned a lot from you. So I'm pretty sure that our audience has some burning questions. We have about 25 minutes left. So, and we have 2 rooms where questions can pop up. So there is a room where all the panelists are. There are also colleagues from the government. I see already one question from one colleague. He would be able to unmute himself later and switch on the video. Others I get on a different channel. So I will try to serve both audiences. And let me start with a question from Prudence from the Malaria Consortium to Dr. Avdesh. Dr. Avdesh, Prudence from Malaria Consortium is asking, is the problem of G6PD very high in India? And everybody who gets a question, please keep it, let's say, to the point so that we can take a lot of questions. Dr. Avdesh.
Thanks, Jost, for that question. The prevalence or incidence of G6PD deficiency in India is not actually it varies from areas to area and communities to communities. There are certain communities where the prevalence is higher, but we do not have a nationwide data also. We have some studies which are basically localized studies. But as of now, since we are using 14 days actually primaquine, so far no such case has been reported because of the side effects of that. But those communities where the actually prevalence is supposed to be higher, so that's the concern, because we would be requiring actually the point of diagnostic care there. I hope I answered the question, because the data is specifically not available across the country.
Thank you, Dr. Avdesh. I have a question, actually 2 questions to Carrie. Maybe I start first the one I got via my chat channel, and then I will ask Dr. Rajiv Tandon to be ready to ask himself the question. First question to Carrie from Aparna Anathakrishnan from HITAP, Thailand. What economic evidence, costs and outcomes on existing and new VIVAX interventions are available that assist policymakers in decision makers? Can this be understood as an evidence gap?
Great, thank you.
That's the first question. Can I just, you want to take one by one, or?
No, go on, we'll take one, that's fine.
And then Dr. Rajiv, are you there? Can you just switch on your mic and just quickly say your question?
Yeah, Carrie, what I was asking was, and you very beautifully explained the pathway that which you called actually paving the road ahead to save time for introduction. But you did highlight a component which was health systems. Within the health systems discourse, the issue around resilience is a huge issue that is being discussed and debated. So when the malaria groups look at introduction of innovations of diagnostics and devices within health systems, is resilience used as a cornerstone?
Questions are clear, Carrie? Over to you.
Yes, I think so. So I'll start with the first one. So thank you for the question. There has been some work done on cost effectiveness of the new tools, or of some of the new tools. Dr. Angela Devine's work speaks to this. And some of that has been done in Thailand. She's looked and found that the use of the qualitative, I think, RDTs would avert DALI, or would reduce recurrences and potential hemolysis as a result of primaquine. But that is limited, I think, by the data that we have on hemolysis associated with primaquine and mortality associated with Vivax. So you could say that, yes, that this there is an evidence gap. I think she's done some global studies as well. But the cost effectiveness is obviously dependent on a number of factors. So the epidemiology of Vivax, as well as, for example, the G6PD prevalence in this region. There's quite a large variation in G6PD prevalence, and up to sometimes 30% in some groups, for example, in Myanmar. So those are quite key factors that drive variability in that, and whether the tools are cost effective or not. So yes, I would say that it does continue to be an area where we need to produce more evidence on that to inform national programs, which we're hoping to do, for example, through the Brazil study, and possibly in this region as well. On the second study on resilience, I'm a little bit stumped, I'll admit. So our focus in terms of the health system strengthening has very much been on where the new tool, what needs to be strengthened to integrate those new tools into the health system. I think some of those health system strengthening pieces are obviously important for other aspects. I mean, pharmacovigilance, for example, isn't just an issue to do with malaria, it's to do with any drug, any medication that's used. So in that sense, working with the FDAs and working with the pharmacovigilance units, I think allows us to improve the resilience of the health system in terms of that particular component of safety. In terms of, let's go back to process innovations, and perhaps it's not quite resilience, but perhaps it's more preparedness of the health systems. You know, understanding the policy change processes, you know, I think everyone understands it has been a bit of a black box, or it is a bit of an opaque process, because, you know, what triggers policy changes, what goes into those decisions that are made is quite unique to every country. So mapping those processes out and understanding what those delays are, I think, again, is not just useful for the new innovations that we're talking about for Vivax, but also, you know, you could say they're useful for COVID in extraordinary circumstances, or for any other of the new, for example, ACTs coming down the pipeline as well. So I hope I've answered your question there, Dr. Rajiv.
Thank you very much, Kerry, for taking two questions back to back. I have another two questions, one coming from our group in the other room. And this question is probably, I assume, either for Robin or Gonzalo, or whoever will take it. Is there any update on when more sensitive diagnostics for P-Vivax will be available commercially? And I see in the chat here in our room, PASS is advancing new diagnostic tests for G6PD deficiency that may support P-Vivax elimination efforts. What is the status of this tool? This was asked by Jayita Chaudhry here. I guess, Dr. Gonzalo, maybe you definitely want to take probably the second question from Jayita, and then maybe Robin, do you want to add on?
I suspect Gonzalo is better placed on both questions. I'm not really in a position to answer the first one accurately.
Okay, Gonzalo.
So the first question, there are tests that are already registered in country, both the CareStart qualitative test, which I said, as I mentioned, you know, a lot of data was generated, and there was a beautiful meta-analysis recently done by Menzies School of the data that's been generated on the performance of that. And unfortunately, it's on hold, the availability of that test. But we hope that that will come back online. And then the SD biosensor standard G6PD quantitative test is also registered in many countries. It has got ERPD approval for procurement with global funds. And also it's going currently through regulatory review with the Australian TGA and the FDA and we'll be submitting to WHO PQ shortly. So I hope that answers the first question. We do know that there's other products in the pipeline, and we really do encourage those because we think having a healthy competition of products is absolutely essential. For the more sensitive tests for Vivax, I think there's a lot of things coming down the pipeline. We know of RDTs that have improved lower sensitivity for the LDH, which is the analyte that RDTs currently use. I think those are still, honestly speaking, about 2 years away from entering the market, given what we know of where they are in the development process. But they do represent a significant improvement on RDT performance. There are new technologies like the HEMEX technology that was mentioned earlier in this panel discussion, which looks like it will, it's an innovative technology that may improve the sensitivity. The data looks quite promising on that. And then there's new approaches that are being advanced by FIND and Mr. Pasteur and other colleagues around serological markers for malaria, for Vivax malaria, to try to get to those hemozoin those liver carriers who don't have parasites circulating in the blood. And I think there's a lot of very exciting work about how that can really improve, reducing relapse and the big contributors to the burden of Vivax in the community.
Thank you, Dr. Gonzalo. I have about 5-6 minutes left, and there is a question reaching me on my special channel here. How can countries, especially low-income countries, overcome high cost of mandatory quantitative G6PD testing to prescribe tifanoquine? Is there anybody who would like to give a short answer on that one?
I can give a short answer and maybe someone else can complement. I think that, as we said, the epidemiology of Vivax is highly variable. We've got countries where NMCPs have identified hotspots of Vivax, for example, in Myanmar. And I think deployment of the tools, and this is where the feasibility studies come in useful, is figuring out where they can be deployed. We're not going to scale these tools up nationally if there's no point to doing that. We can target the resources and allocate resources to where those tools will have the greatest impact to try and overcome some of the cost barriers.
Okay, any additions from other colleagues on the panel? Okay, so that's not the case. I see we are actually reaching the time where we decided we can maybe also wrap up a little bit early. 2 hours are very long, and this is the first session where we don't offer you a coffee break. So let's maybe wrap up the session. And I would like to invite Dr. Marie Lamy, Director of Access and Policy Team at Appelmar, maybe to sum up a little bit the roundtable discussion in the form of some key messages. She listened very carefully. She's also responsible for organizing partly this event today. So Marie, can you come on and maybe share some of the key messages you have heard while listening in?
Sure, Jost, thank you very much. So this is not an easy task. There has been really rich discussion from our panelists, so thank you so much for that. It's going to be hard to summarize in just 5 minutes, but I will give it a shot. So what I believe we heard today is basically that to defeat malaria, we need to harness innovation in health commodities, very simply. In fact, we need to address the disease from every angle. So with tools like new insecticides and also technologies to prevent transmission more effectively, or even to monitor foci. We also need the right diagnostic tests to detect cases and G6PD deficiencies, and medicines to treat all forms of malaria effectively. So used together, it's really this suite of tools that supports the malaria response as a whole. what the Malaria Game Changers series has shown us over the last 3 sessions, including today's, is that in times of COVID-19, what is most important is first to sustain access to existing tools. So maintaining all services and budgets for essential commodities like malaria tests and drugs. So the domestic budget question was actually highlighted as one of the main bottlenecks in our poll earlier. And this was also mentioned actually during yesterday's dialogue on financing for malaria. So I also think that elimination requires, as we heard today, better use of existing tools, but also speeding up the introduction of new tools safely where they are needed. The innovations that we spoke of today particularly apply to the radical cure for Vivax, and our panelists spoke of point-of-care G6PD tests and shorter treatment regimens for Vivax, such as 7-day higher-dose primaquine and single-dose tafenoquine. And we know that the World Health Organization also sets policy guidelines on the use of these malaria commodities. And recently, the Global Malaria Program announced a revised 3-part policy pathway to better anticipate, develop policy, and optimize uptake of these commodities. And this revised process includes a coordinated approach for both pre-qualification together with policy recommendation activities to shorten the timeline, essentially. So the point that our panelists touched on today is also around how countries can be ready to introduce a new tool and to test its feasibility even in preparation for a WHO recommendation. And we were fortunate to hear of Thailand's experience from Dr. Darren by video earlier. And in fact, I just wanted to add that we worked together with Thailand, MMV, PATH, and the TGA to map out the process for access to radical cure in Thailand. Carrie also briefly mentioned that. We actually developed a video to share this policy roadmap with you, and we have it in the form of a brochure, which is also available for you on the APMA website. I believe the link will pop up on the chat box shortly. So in the meantime, just as a little pause for now, I propose that we take a look at the summary video together.
Thailand has made tremendous progress towards malaria elimination since 2013. As of 2019, 35 of 77 provinces are malaria-free. However, the country is still faced with challenges. Vivax malaria is one of them. It is harder to cure than other forms of malaria. It lies dormant in a person's liver, can relapse causing a new bout of malaria, leading to renewed risk of transmission. This underlines the need for additional reliable, well-tolerated, and effective radical cure for P-Vivax, which will involve 4 steps. 1. A malaria diagnostic test. 2. A diagnostic test to determine glucose 6-phosphate dehydrogenase, or G6PD, enzyme activity. 3. A drug to kill parasites in the blood. 4. Another drug to kill dormant parasites in the liver. As the current treatment is a 14-day regime with primaquine, follow-up by health workers and patient adherence is a challenge. A new single-dose treatment, tafenoquine, is available to supplement current treatment. Thailand is leading efforts to bring about universal access to a Vivax radical cure across the region. It is the first country in Asia to approve and register tafenoquine as a single-dose radical cure for Vivax malaria in December 2019. Deployment of a Vivax radical cure, whether primaquine or tafenoquine, requires screening of patients for G6PD deficiency. The diagnostic test that quantitatively measures G6PD enzymatic activity has also been registered in Thailand. Through the Indo-Pacific Regulatory Strengthening Program, the Australian Therapeutic Goods Administration worked jointly with the Thai Food and Drug Administration to support the review process of this new drug. The collaboration between the Thai FDA and the Division of Vector-Borne Diseases to introduce tafenoquine is an example of how disease programs and regulatory authorities can work together. However, registration of the drug doesn't imply the immediate rollout of the treatment regime. The introduction of new tools needs to suit the context within which they will be used. Thus, Feasibility studies will be conducted to determine which radical cure regimens can be safely offered at different levels within the health system. Tafenoquine, along with quantitative G6PD testing, will be piloted in the Yala province of southern Thailand. With the feasibility studies underway, Thailand is also rolling out G6PD testing with the current treatment. Healthcare workers will be trained on how to safely administer the cure after testing for G6PD. Administering tafenoquine requires the monitoring and reporting of adverse drug reactions, particularly in relation to hemolysis. A strong pharmacovigilance plan is being rolled out. Other radical cure options are also being explored, such as using primaquine for 14 days along with quantitative G6PD testing, or using higher dosage of primaquine for 7 days. Depending on the results from these feasibility studies and other evidence on the use of current or new tools, the national treatment guidelines for malaria may be revised. Tafenoquine as a radical cure for vivax malaria is being used as a case study for the new harmonized World Health Organization pre-qualification and policy recommendation process. As the region awaits World Health Organization's recommendation, countries can plan for its introduction by preparing their health systems. Each country will need to choose the radical cure strategy and tools that work best for their context to achieve the goal of malaria elimination by 2030.
Thanks for that. So we can see from this summary video that there are some great lessons to be learned from the Thailand experience in terms of being ready to introduce new innovations. Not the least is the value of reliance between regulators to share resources or knowledge in the view of speeding up review processes. There are many examples of this through the regulatory strengthening program, as we saw, and other collaborative registration mechanisms spearheaded by the World Health Organization. What we also heard is that there's no one-size-fits-all approach, and that each country needs to adapt the use and the application of different malaria tools to best respond to their own local challenges. So essentially, continued innovation to improve our life-saving tools from tests to treatments and even vector control technologies will ensure that malaria is not a death sentence, even in areas where resistance to insecticides or artemisinin combination therapies is developing. These tools need to adequately protect both women, men, and also children. So new technologies are really essential to stay ahead of the disease and the mosquito, but these innovations are also only as effective as the supply chains that deliver them, the education and the capacity building programs that empower communities to implement them, and the surveillance and data collection systems tracking them, also the regulatory systems that guide their introduction. What we also heard is that senior officials really have a collective role to play in identifying and resolving access bottlenecks. And one key takeaway that was also part of the poll results is that we need to encourage more collaboration across sectors and agencies, from disease programs to regulatory authorities, and also even to ministries of commerce and finance involved in the procurement and supply chain. So this is about accelerating efforts to elimination, and 2030 is only 10 years away. So the longer we take to end malaria, the higher the financial and human toll. So really investing in innovations is crucial to both protect the gains that we've made so far and to accelerate progress. And this is really part of the message that we would like to share tomorrow also during the senior officials meeting. So with that, I turn back to you, Jost. Thank you very much.
Thank you very much, Dr. Marie Lamy, for sharing some key messages. And one of my final tasks is to hand back to our co-chairs, Dr. Lê and Dr. Sandy, to give some closing remarks. Over to you.
Thank you, Mr. Joswana, and thank Dr. Marie Lamy for your summary of the discussion. This is a very interesting dialogue to me, where I can learn, and I was convinced with the discussion, with experience sharing from Indonesia, Thailand, India, and as we have heard about from our panelists today, new tools take time to introduce due to technical and policy barriers. And senior officers have a role to play in helping to resolve the bottlenecks. And collectively, we need to support an enabling environment for the timely assessment, registration, and policy introduction of new innovation, including to detect and treat virus, but also to support our response to other emerging health threats, or even drug-resistant malaria. This, in fact, will be the topic of the next Malaria Game Changers series in November. And I will take the pleasure of co-chairing the breakout session on innovation during the AMA Senior Officer meeting tomorrow, and relaying the outcomes of today's discussion. And two key points to discuss will be how senior officers can support the building blocks for a stronger regulatory system, and how can we encourage more collaboration across ministries or agencies to improve access to this game-changing and make sure they are accessible to the most vulnerable and hard to reach population in time. And this marks the end of the third and the last Malaria Week dialogue this week. And thank you all for your time, attention, and active participation. And now, yeah, over to Dr. Sandy Lin. Yeah.
Thank you, Dr. Lei. And thank you, everyone. Let me share a few comments today before closing on the discussions that we've had and also on where innovation might fit in. Marie mentioned earlier about financing. We also saw from our poll today about the importance of financing and domestic budgets for essential commodities and for procurement of essential commodities. This resonates with the session we had yesterday on health financing. It was recognized that the COVID pandemic has had an impact on the economy, which has resulted in a decline in revenue. This means that the governments will likely resort to budget cuts and reallocation of resources. So what could be done, as was mentioned earlier yesterday, within the subsector budgets, that certain budget line items for malaria should be redlined, meaning, for example, for surveillance, drug pipelines, etc., and that these items should be maintained at all costs. So this is both an advocacy message, but also a message that all of us collectively could give for the SOM meeting tomorrow. I think we should also take advantage of the natural convergence of both malaria elimination and our response to COVID-19 pandemic preparedness. And of course, this could be supported through innovation, improving regulatory framework, as mentioned earlier, and I think more importantly, operationalization of these frameworks and what this means at country level and for different ministries and regulatory authorities. Access to diagnosis and treatment, we can support countries' readiness and address infectious diseases such as COVID and also for malaria. And in doing so, I think we can contribute to the broader regional health security agenda. So let me conclude here by thanking all of you for your active participation in the session. I know that we all have competing priorities in dealing with this current pandemic, but I think for many of us, the fight against malaria and the effort to improve access to new technologies should remain a top priority. So thank you once again, and let me revert back to yours.
Thank you to our two chairs, Dr. Lei and Dr. Sandy Lewin, for their closing remarks. And that's it from us. We, of course, all from the organizers I hope you had some interesting takeaways for our third edition of the Malaria Game Changer series. There is another one in November and then the fifth one in December. You will be seeing 3 poll questions on your screens in a moment. We would like to ask you to give us a little bit feedback. It takes less than a minute. And to remind you one more time, tomorrow, the Malaria Week will finish with the much awaited senior officials meeting starting at 1 p.m. Hanoi time. And once again, thank you, Dr. Lei, for bringing the main outcomes of this discussion to the group tomorrow. And thanks to all of our speakers today, and of course to the audience here in this room and in the other room. We hope you will have a good day, stay safe, stay healthy, keep up the important work you are doing, and thank you very much for joining in today. That's it from us today. See some of you tomorrow virtually again. Good day, good evening, or if you call in from very different time zones, good morning.